Hello, everybody. Welcome to this Insight webinar on behalf of IPC partners, the Healthcare Infection Society and the Infection Prevention Society. Phil and I are delighted today to be joined by Kerry Holden, and she's going to be talking to us today about addressing healthcare inequalities in IPC. So this is obviously a really important webinar. There's going to be lots of information that we hope, as with all of our Insight webinars, you'll be able to take and implement change in your day job. That's what we're here for. Hello, Phil. How are you?
Hi, John. Great. Excited to hear Kerry talk.
And welcome, Kerry. Great to see you.
Thank you. Thanks so how much for having me, and no pressure, Phil, but I shall certainly try and do us all justice.
You will. You will.
So, Kerry, Phil and I were talking before, and we were going to ask you, what got you into this area of health inequalities and IPC?
Yeah. I describe myself as an enthusiastic amateur with most of these things, but I think, like a lot of us, hopefully I'm not unique, and I'm hearing a lot more people kind of coming on this journey for health inequalities now. It was the lived experience. It was actually hearing a fantastic work of somebody who's doing, it was actually a tissue viability lead nurse who was doing some fantastic work with prevention of wound infections and subsequent bacterial infections in a local kind of trust within the southwest where I work, and was making such huge differences to the quality of patients' lives by doing a slightly different approach, by doing things that probably didn't seem the conventional way of approaching infection prevention and control, and was doing and making a difference to people's lives. So I think most of us, when you hear a patient story and you see the impact that work and the work that you do has on an individual's life, it definitely pulled it in for me, that I was hooked, I think, at that point. So yeah, definitely needs to do the same in my area of work as well.
Okay, great. And Phil, what's piqued your interest?
I think, to be honest, it's a very similar story to what Kerry said, but hearing Kerry talk about it in other formats as well. And I think then diving into it in the day job as well, when I was working at Oxford, and understanding a little bit more about the impact and the approach. And it's kind of one of the things I love about healthcare is that those patient stories are extremely powerful. And I think the more that I've looked into the topic area, it's actually frightening, how much of an impact health inequality can have when it comes to infection rates. So really excited to hear Kerry's perspective.
Okay, yeah, thanks both. And from my point of view, I think I was aware of health inequalities and discrepancies in infectious disease impact before I joined the NHS. But when I joined the NHS, I was really confronted by that fact, by some of the data that's behind me, which is the rates of AMR based on deprivation index category, with the most deprived areas having the most AMR. There's no getting away from that. I think the question for me is, what can we do to actually make a difference here? But we'll come back to that after you've spoken to us, Kerry. So before I hand over to Kerry, let me just give you a little bit of background. So if you scan the QR code, that will take you to the schedule of events that will be upcoming over the next weeks and months. So Insight webinars, what we're trying to do here is give a really concise overview of an important topic area, like the one today. We want to generate discussion, so please, it's going to be quite a busy webinar today based on registration number. So please do put general comments into the chat and use the Q&A function for any questions. My advice is get your questions in early. I think we're likely to be inundated today and probably won't get through the questions. So please put your questions in early and use the upvote function to push the questions that you like towards the top of the queue. This webinar is CPD accredited with the Royal College of Pathologists for 1 CPD point. We want to exercise critical thinking as well. So don't take anything Kerry says at face value. Go away, explore it, test it forwards and backwards, and make sure that you agree with it as well. We're keen to build confidence for your independent research and studies. You can go away from here feeling empowered and emboldened to pick up a research paper and look into things for yourself. And we want to foster this network of enthusiasts and have a bit of fun. So with that said, Kerry, I'm going to stop sharing my slides and hand over to you to speak to us about addressing health inequalities in IPC.
Is my screen sharing as a start? It's always a good start, isn't it? Brilliant, fantastic.
Yeah, perfectly.
Brilliant, fantastic. So my session is a little bit of tale of two halves, let's say. So the first session is the first part of the session rather is to give you a little bit of insight about health inequalities and how particularly health inequalities impact infectious diseases and the patients that we will often come into contact with. And then the second half is hopefully to give you a little bit of insight into kind of things that we can do to influence and have an impact on health inequalities in infection diseases and infection control and infection management. And hopefully give a little bit of steer about some of the work that we're doing in where I work in Gloucestershire. I've got some examples, some other case studies, but it'd be great if you're able to share some of the amazing work. And like I always say, for anything that I do, is the power of sharing the kind of the amazing things that we're doing can mean it can translate to other areas and have an impact on the other people and communities that we look after. And I always start with this slide when I talk about health inequalities because I just think really reinforces that this is not a new issue, and the impacts of not addressing inequalities in health in particular are the most devastating because they can result in death. And Martin Luther King was somebody who really brought this in 1966 and made a clear point of how we need to make a difference. And if I can encourage anybody to go and do some streaming a bit later, I would encourage you to go and have a look, if you've got Disney Plus or Hulu, to go and have a look at this documentary called Aftershock, which is even in 2022 demonstrates the impact and the kind of the health injustice and inequalities that are affecting Black mothers' lives in America and the high increase in incidence of postpartum death as a result of those inequalities. And it's called Aftershock because it's supposed to demonstrate the ripple effect like a tsunami has on loss of a mother's life as a result of not preventing an inequality in health. So, oh, sorry, I've gone a few slides too soon there. So when we talk about quality in care, we often talk about the Institute of Medicine's 6 domains of healthcare quality, and we talk about safety and we talk about effectiveness, and those are aligned often with our CQC if you're in England for our registration requirements. But do we really often talk about equitable health and how we're making sure we're delivering care that it's not going to be unfair and inaccessible to people based on different personal characteristics? And on our challenge, and my challenge to you hopefully by the end of the session, and is just to inspire a sense of looking at things differently about how we can deliver equitable infection prevention management to our patients, because often it's those injustices that they face in their lives that often are unavoidable, that we can hopefully have an impact on to make sure they have better access to the care that we can deliver them. So we are in a position where health inequalities and disparities are worsening. We know the pandemic really shone a light on health inequalities, particularly for those that were from different ethnic minority backgrounds, where they experienced a higher prevalence of morbidity and mortality as associated with those infections. We've got a cost of living crisis that means those socioeconomic disparities are also widening. And we see an increase in disadvantaged groups. So, we see higher risks of childhood obesity, mental health, morbidity, and mortality associated with maternal deaths, as I described before. And we know the NHS is pressured, and that is the weights are more likely to be faced by those that are in deprived areas, particularly those that are not likely to access because they might not want to access or they may not feel able to access healthcare. And this was a reasonable quote, I think, that really shines a light on the issues that we currently have from Emma Wilkinson in the BMJ, that said children born in 2008 are yet to hit their 18th birthday. They might be coming up to it soon, but they've faced a global financial crisis, periods of austerity and a pandemic, and now a cost of living crisis. And we are in a space where, budgets are being cut. So these things are only going to get worse. So what are health inequalities? And I've put some QR codes throughout it, and I do encourage you to scan them if you can. The King's Fund is fantastic as a resource to have a look at health inequalities and some of the things that we can be doing. NHS England also have some fabulous resources that I'll share throughout the sessions later. But health inequalities are essentially avoidable. They are preventable, they are systemic, and they are unfair, and they influence and impact the health of different groups of people. And those groups of people are often categorised into 4 different domains. So those are often based on income, so socioeconomic factors, where you live, the geography and the regions that you live in, specific characteristics, and those can be in the form of ethnicity, sexuality, and then those socially excluded groups, or what we call inclusion groups. And there often are people that experience generally kind of more ill health because of the kind of conditions they might be living in. They might be people that are migrants, they might be experiencing homelessness, sex workers, for example. And some people will experience more than one of those categories. So the inequalities are multiplied depending on the different types of advantages, disadvantages that they face. And as I said before, I won't go on too much of it. I will say that unfortunately, we have been trying to address health inequalities for a long time, and they're not new. When we look at reports from Douglas Back and Donald Eckerson back in the kind of the 80s and the late 90s, there was really an assessment of health outcomes vary, particularly based on social class and where you live and your deprivation that's faced on that. We saw higher incidences of mortality linked with working classes. They found higher instances of, higher instances of lack of coming into prevention activities in particular and engagement with that in those sorts of particular those lower economic groups. And yet these reports very clearly saying recommendations for policy change, that we need to look at how we support our families and children. These, they didn't necessarily come to the fruition. And we then see this as evident in the Marmot reports in 2010 and 2020, where for the first time, particularly in 2020, life expectancy, particularly amongst our higher sort of deprivation areas, weren't improving. Definitely encourage you to have a look at the Marmot book, the Health Gap, the Challenge of an Unequal World. Again, it reinforces the kind of a slightly different approach on how we need to tackle health inequalities. And as I say, it's not something that's brand new in 2019. Public Health England, as was then, reinforced the need to look at how we address health inequalities as a threat to public health in England. Ironically, in this same paper, they described a novel disease X that becoming, and they mentioned about the emergent diseases was a concern, and shortly after we had the pandemic for COVID. So we definitely know that these are actual threats that are not just threats, but things that can be actualised by the people we look after. So when we look at health inequalities, we often see this, and I'm sure you've probably seen this visual before, but I just think it really reiterates that we need to move away from using the word equality and saying that we give everybody the same, that will mean that we be mutual benefit, because it isn't the case. And this visual is very clear to say that by giving everybody the same thing doesn't mean that everyone could see the baseball game behind the fence. What we do need to do is give people more individualized, targeted things that they need that's going to help them to be supported to actually see the game, to access the healthcare that they need. But what we often face, unfortunately, in the reality of the world is that often more people get more than what they need in, and some people get less, and there is a massive disparity. And what we really need to do is to look towards a more of an approach where we remove the barriers completely, the systemic barriers that are there, so that we enable everybody to have access, and the cause of the inequity has actually gone away. And then hopefully there's some fantastic things that are coming through that is going to demonstrate, particularly in England, apologies, this is quite England-centric, to say that hopefully we're going to improve our approach to addressing health inequalities. And the NHS standard contract has started to support commissioning of services to address health inequalities. We've seen the National AMR Action Plan, particularly again the 5-year Action Plan for Antimicrobial Resistance, has demonstrated a need to address health inequalities. But before we go into a little bit more of the kind of the data, I just thought I'd give a little slide about some of understanding the metrics, because there's lots of information. We use lots of letters in a lot of our worlds, don't we? And actually, it's really important that we kind of look at what we're talking about. So, index of multiple deprivation, and this is our in England how we measure and assess socioeconomic equality. So, IMD1 is the most deprived, with IMD5 being the least deprived. And it's assessed, but using those several different domains that you'll see: income, employment, education, health, crime, barriers to housing, service and living environment. And each of the kind of areas that we all live in by region and counties are described using this sort of IMD, and that's normally used to reflect sort of things like admissions to hospital, and it'll use that to kind of demonstrate the health inequalities that we often see. Core 20 is used in the UK as well, and it shows the most deprived 20% of the national population. So it will look at those IMD1 areas, and it just shows you geographically where they are. And then the International Classification of Diseases is useful because it's something probably you'll see in reports, particularly UKHSA. I've just released or recently released a report looking at health inequalities and infectious diseases, and they use these ICD code lists that are kind of from the World Health Organization definitions as well, where we look at defining conditions so that we can easily count them, and then underpin metrics specifically related to things like hospital admission and mortality, and that can therefore enable a bit more of a fairer comparison about the impact of health inequalities, particularly dependent on particular infectious diseases. So having that in mind, this is quite helpful because it just gives you a little bit of insight. And this was what was on John's background earlier. This is the AMR burden, particularly from a bloodstream infection point of view, and it looks at demonstrating the social deprivation and the incidence of per 100,000 population of bloodstream infections. And this, again, this was something that really resonated with me when I was doing some work, when I first started doing this work, was how we often are so focused on our gram-negatives bloodstream improvement work and our gram-positive improvement work and making sure we prevent those bacteremias. Have I ever really looked at which patients are affected on a deprivation level? I might have looked at where they've been on a ward maybe, but not necessarily where they live geographically. What are they experiencing from a socio-economic background point of view? And this really demonstrates that those that are the most deprived have the highest incidence of our bacteremias. And it makes me think, should we be doing things slightly differently in our approach? And hopefully that will influence you guys to think about how you might look at your surveillance and data and look at how you might target some of your interventions, particularly from a bloodstream infection point of view. And similarly for flu, I won't go too much detail on this slide, but essentially you'll see that there's higher instances of flu admissions and COVID admissions, particularly those from the most deprived areas, like significantly higher compared to those that were in the least deprived areas. And then also bringing in ethnic minority groups in this data set as well. They found a persistent increase in higher admission rates for those from a Pakistani ethnic group, and Black, African, Caribbean and Black British ethnic groups also had a higher incidence of admission from an influenza point of view. So again, really reiterating, what's our flu management programs look like? What are we doing from our prevention strategies for flu? And are we targeting the groups that are more likely to be need our admission because they're more likely to be more vulnerable and actually have a worse outcome as a result of their inequities that they face? And then the pandemic, again, I've already reiterated that there was definitely a correlation not only with ethnic minority groups, but with the most deprived having more than double the rates than those counterparts in least deprived areas. And what I really wanted to bring out from this slide is really the priorities. And it says we need to protect the most vulnerable. And that, I think, is the sense that I'm constantly thinking about how when I look at my work plans and what I'm doing in my roles is, am I protecting the most vulnerable, or am I doing things that's quite universal and quite standard in approach? And that change and nuance might make a difference in how we look at things. And then accelerating prevention. I come to work to be a preventionist, not to be a controller or manager of outbreaks or infections. So how can we make sure we're accelerating those programs that will make the most difference to those that maybe not necessarily engage in prevention strategies, but also are more likely to have adverse effects if they aren't engaging in those strategies. So I would encourage you again to have a look at the Health Inequalities in Health Protection Report 2025. There are some limitations of this data set because it is using emergency hospital admission rates as a kind of as a proxy for infectious disease burden. It is clearly going to be underrepresented. Not every patient who has an infectious or person in the community that has an infectious disease will need to be admitted into hospital, and nor will they be, they might not be severe enough to need it, but they could still have an impact on their lives. It might mean they might not be able to go to work and be able to, particularly if you've got 0-hour contracts and people that haven't got the sort of support from a sickness, getting financial support, then these all have an impact. So it is important to kind of recognise this is probably just really the top of the iceberg, really. So when we look at, again, infectious disease admissions from a deprivation point of view, so as early as 2023, 24, those that were being admitted to hospital with an infectious disease or an infection were nearly twice as high for people in the 20% most deprived areas. So again, those core 20 populations. Respiratory infections had the greatest inequality, and again it makes me thinking, are we doing enough for respiratory infection prevention? Are we sometimes a bit targeted on the kind of the smaller infections that we often, that were very kind of key on, the healthcare associated infections that were very keyed into thresholds, like C. diff, for example? Are we doing enough to prevent respiratory infections that could have a knock-on effect down the C. diff down the line because we're minimising the impact of antimicrobial use? And we know that admission impact is huge from a deprivation point of view. And these are just some kind of graphic to really demonstrate the kind of those from the IMD1, who again, most deprived areas having the most infections presentations to A&E. And then similarly experiencing for the ethnicity is similar to what we saw with flu and COVID, that those patients and coming into hospital from a non-white British group were much more higher rates of attendance, statistically significant actually, compared particularly in the 8 ethnic minority groups out of the 15 had higher admission rates. And I just took TB as an example here from that report, because I think a lot of us are doing a lot of focus on TB now, where we saw higher instances in our Asian, Indian background, Black African background patients compared to a white British, quite considerably higher in those populations. So are we doing enough to focus TB prevention strategies, screening strategies, and optimizing management of patients from those ethnic minority groups? And looking at geographical difference, there was a similar kind of a higher burden of disease in the northwest of England compared to the national average. Inclusion group health groups I'll go through a little bit more, but these are groups experiencing social disadvantage, as described before, normally homelessness, people seeking asylum, people in prison or having contact with the criminal system, people inject drugs or have alcohol dependence issues, do face a disproportionately higher disease impact, and this was evidenced particularly with chronic hep C. And this is not costing the NHS a considerable amount of money, and actually what is avoidable healthcare costs. But that's kind of the minor bit really. If we look at it, we can use that money then to kind of just redistribute that to keep people healthy, rather than responding to the impact of an inequality, would be much better. So I mentioned about vulnerable groups. The inclusion health groups are really important to understand, because we know that these health group, these particular individuals often face stigma. That's consistently identified as a barrier to accessing healthcare. It leads to delays in treatment, worsening physical and mental health outcomes, and therefore increased risk of death. And we need to know where these groups are, so that we can target them with specific interventions. Because actually what we know from inclusion health groups, they're 11 times more likely to die from an infection compared to those that are not. So it's really significant that we need to tackle these. And you'll see these inclusion health principles are the kind of the 5 commitments, particularly from NHS England, about how we need to address these inequalities for these individuals. And this is where the Core 20 plus 5 criteria programs have come from. Core 20 have described are the most deprived 20% of areas. The plus populations, or the plus populations, are the normally locally driven population groups that often experience inaccess or issues with health inequalities in your local area, and often are inclusion health groups, if I'm honest, but also could be ethnic minority groups. And what you'll find from that is that the NHS England, which is a driver of this programme, have identified 5 focused clinical areas requiring accelerated improvement because of the impact that they're having on those particularly deprived communities and those groups that you've locally decided that are facing those inequalities. And there is also the same for children as well. So why does this matter? And I'm bringing us back a little bit, closing the loop a little bit, because I think we have to never forget about the person. It's easy to talk about statistics and they feel quite big, don't they? But these are really, this is the thing that brings home to me why we need to do something differently. So if you're a homeless man, your life expectancy is 46 years. If you're a homeless woman, your life expectancy is 44 years old. If you have a learning disability and you're black, your life expectancy is 34 years old. And if you're a black woman, you're 4 times more likely to die in childbirth or in the year following. There are specific ones related to Core 20 population groups as well, where we see a higher incidence of late-stage cancer diagnosis just as a result of attendance to A&E, and then similarly admissions in winter, particularly as a result of worsening COPD, being responsive to those Core 20 plus populations. I mean, those always, just every time I read those out, they're just stark, aren't they? They're just massive to think in this day and age of modern day healthcare and the amazing things that we've been able to do. We have this injustice and life expectancy of people we shouldn't be seeing this really. And I will just briefly just say that we can hopefully contribute to the evidence. This is a really good health inequalities and infectious disease systematic review, and the bits in red, basically through their systematic review that they did, they found that there was no evidence they could collate, or no literature that was of the quality to be able to include in their systematic review. And what worries me is that there's quite a significant amount of red on there, which demonstrates they couldn't find that evidence. So, you know, TB in vulnerable migrants. I mean, this is 2023, so I'm hoping that through the work we've done, particularly in asylum hotels and with our vulnerable migrants, we'll have improved the quality of the evidence that's out there. But to not have anything about TB and vulnerable migrants, and vaccination in people experiencing homelessness or rough sleeping, and in pregnancy and maternity, just doesn't feel right. So we definitely need to contribute to the evidence base to support this, because they again similarly found very similar levels of high incidence of infections and infectious diseases, particularly TB, HIV, sexually transmitted diseases, and under vaccination in those from ethnic minority groups, those that for sexual orientation of men who have sex with men, and in the inclusion health groups. What was also interesting, they also found with those that had higher incidence of social deprivation. They found that childhood vaccination compliance was lower with those that had younger mothers and parents, and they also found that there were significant gaps in the research related to religion, disability, transgenderism, and pregnancy. So again, just making sure that we need to fill some of those gaps in. So what does this mean for IPC? Well, it means significant injustices in terms of the prevalence of infectious diseases. We see it inequitable exposure, predisposition, transmission, susceptibility, and treatment delays, which means we're going to have sicker people attend later with fewer safeguards. And actually those people might be looking after other people in a household that are living through similar conditions, and therefore are more likely to have others similar conditions, and who looks after them and who's going to be caring for them if you're somebody has to be admitted to hospital. So we really need to understand and tailor our work streams and be less universal. And I know there was a point where we need to do that. We needed to apply a standardized universal approach to infection prevention management, but I think my challenge to us now is that we need to move away from that and add in the nuance and addressing the different needs of people in our populations to help prevent and manage and optimize management of infectious diseases. So one size does not fit all. So some of the actions that we can take. So let's look at prevention, I think, and targeted actions. We need to embed health equity. We need to apply our lens of health equity and addressing health inequalities across everything we do. It needs to be part of business as usual and not an afterthought. And we need to make sure then we're designing those interventions, ideally with the people and the communities that are underserved and not able to get access to some of the care and treatments that we were providing. So these are going to be really meaningful interventions, and actually addressing those that are more likely to have these infectious diseases as a result of those inequalities. We need to strengthen prevention across the whole system, and we need to look beyond our front doors. Like me, I work in a hospital, and it's easy to think I need to just address the things that are going on in my own front door and my own beds. We need to remove those barriers. If we're going to improve prevention properly, we need to look at the whole patient's journey, the whole pathway, and the things that will prevent them in the community, and the energies and attentions that I will give to that will have a difference in meaning. That will have fewer admissions, and means, you know, less hospital bed days and fewer healthcare associated infections. Looking at vaccination, we do need to target that, and particularly those with the lowest uptake, and making sure we deliver tailored outreach to underserved communities. So looking beyond the front doors of a hospital, improving access to testing, screening and early treatment, and making sure that we prioritise prevention and treatment for those with the highest burden rather than a universal approach. Looking at our outbreak planning and emergency response, have we really integrated good equity within that? Have we got good access to testing and treatment and culture appropriate communication when those things need to happen? I can't underestimate the importance of collaboration and partnership working, particularly with voluntary community groups where there's that trust is already there for a lot of our colleagues, a lot of our patients, where they trust the leaders and the community people that will often provide some of that information in a much more meaningful way and a much more understandable way, and in a way that is more likely to make a difference. Co-design is so important. We need to make sure we're including our communities and don't assume what will work. And we're really good at doing that. I'm very good at doing that. And I have to stop myself saying, let's not just assume that this is going to make a difference, because I think it will. We have to ask the people that it's going to actually impact, and look at how we support place-based local tailored interventions. So, you know, things like drop-ins and open door policies. I can't stress enough about the importance of using your own data, particularly collecting it properly. One of the drawbacks and limitations of the other data set from the UKHSA is that we don't always label ethnicity properly in our patient records. So we do need to make sure we're doing that. We can use that data so well to be able to see if there's any particular root causes of inequalities. We can look at to see if there's any patients that we need to target action for, and we can hopefully use that to kind of build improvements and interventions for those cohorts of people. It's important that we look at our capability, and as with anything, we need to make sure that we are able as health professionals to be able to deliver good health and equality, and it's really important that we invest in our workforce. So things that we'll need to know about is making sure, you know, we've got cultural and diversity competence. I remember listening, I was telling briefly this earlier about the tissue viability nurse that I listened to, and she was fabulous, and she said, look, listen to people, really listen to them, what matters to them, and don't make any, and try not to make judgments, because we easily do that. Understand that people's lived experience is their lived experience. It might be different from ours, but that's no reason to judge it or I'll make assumptions on their behaviours as a result of it, and influence and affect the care that we give them as a result of it. We know that trauma-informed care is something that we should be exploring and should have understanding of, so that we can respond to that. We need to look at understanding barriers for health awareness. It's sometimes easy to put a fantastic programme of work in, but it's completely inaccessible because you have to go and travel, and who's got the money to pay for the public transport to get there? So we need to make sure we're putting it in the communities where people are accessing, you know, if it might be the local shop, that you go and put an information kind of stand, rather than trying to put it in the hospital where people have to travel to. Communication skills are really important. It's valuable that we make sure we use plain language, interpreters when we can, looking at how we have things translated, and being aware of the low health literacy. And I've got another slide about that in a moment. Safeguarding is also important, and making sure when we're providing access to care, maybe looking at making every action count and every contact count, to look at how they might provide access to other support interventions whilst you're there. We'll need practical skills on outreach delivery. We need flexible approaches, and things like, you know, no fixed appointments, walk-ins, multi-agency working, and continuity of care. And it's really important that the system supports that. You know, you as health practitioners, we need a safe space to be able to reflect on this. It can be quite challenging work. This can be, particularly when you see some of the outcomes and how people are living. It's hard to, you need to know where your boundaries are, and you need that clinical supervision at times to support that. Our leaders need to really prioritise health inequality systematically, and that looks at how we commission and plan and deliver our services to our health communities. You need to look at how that then affects time and resources. We often might need longer appointments. You might have a complete day booked with no bookings in, because it's a drop-in session. So you need to be prepared not to have anyone turn up and not be deemed as a failure. You need to look at how we can fund things slightly differently. And look at how you might access different specialty services that will help you do your job better, and look at how we support ourselves as a workforce. So just some small changes that I just think are really good that we should be considering in all of our, particularly our patient information leaflets and our health literature. You know, a fantastic project that's been done in the University of West England that looks at improving diversity in photographs of medical conditions. I think we all looked at the measles kind of literature that came out, where we started to see looking at rashes on brown skin rather than just the traditional white skin images. When we want people to access services when they're concerned, we need to make sure it's delivered in a manner that they can understand it, and that is applicable to them. And that goes the same for use of simple language and concepts. We know that 1 in 6 people in the UK have a literacy less than expected, and most around about 11 years old. So we need to make sure that information isn't overly complicated. It's clear, it's concise, but it's not patronising, and using pictures to reinforce images, reinforce the language that we use. And the best thing that we can all do is share what you're learning and practices. So some fantastic NHS England Health Inequalities Hub that looks at sharing people's journeys, so particularly programmes they've done to tackle health inequalities. And I would encourage you all, if you've got those programmes of work, to share those similarly. And I'm just going to quickly finish, hopefully, on a little bit of a journey of things that we've done in Gloucestershire, because as I just need to practice what I preach about sharing what we've learned. And this was just, we decided as a system to do this rather than looking at individual providers within the system. We did this together, and we looked at hospital admissions by deprivation. And looks at the index of multiple deprivation, which was really helpful because it gives us an idea that, again, we'd recognised that higher incidence of infections, of patients with infections, were been seen in the most deprived areas. We looked at specifically pneumonia as well as one of those things. We also looked at, there's lots of data out there, and I suspect you'll be able to find lots of health inequalities by just looking at the data that already exists. But I'd encourage you to all have a look at your leader reports. This is looking at the lives and deaths of people with learning disabilities. In Gloucestershire, it was stark. There was a 19-year age gap between those that had a learning disability and those that were in the general population. And we found that the most common cause of death was pneumonia, so an infection-related cause of death that made me think we need to be doing something differently for this, and particularly with higher incidence of, as you can imagine, during COVID. With that, we also looked at our because we saw that there was an increase in risk in pneumonia, particularly linked with oral health and the lack of oral health, particularly in our learning disability populations. We wanted to do the same for other communities within Gloucestershire, and we found that our care home residents, particularly those from nursing and from kind of complex care homes, saw inequalities in access to dental and oral health. So lack of access to services, poor oral hygiene, lots of issues with untreated decay, infections, poorly fitting dentures, issues with lack of training, and not getting appropriate treatment. And there's some financial and administrative barriers, people thinking you had to pay for NHS care and not knowing when to get access to dental care. All of this, I mean, I've put it down there. Sometimes it's easy to forget how these things link to infection prevention. And I just wanted to just demonstrate on that sort of little bit of a slide to say, actually, just by not having good oral health can have an impact on issues with nutrition, hydration, issues with increased UTIs, dental infections, pneumonia. That means more antibiotics are used, particularly when 80%, I think I remember the quote, was 80% of dental infections are treated with antibiotics, which are completely inappropriate when dental treatment is needed. That increases our risk of antimicrobial resistance. That means more hospitalizations, increased risk of HCIs, particularly C. diff, because we're using more antibiotics, higher incidence of length of stay, deconditioning, increased risk of morbidity and mortality, all because of an inequality affecting access to good oral health. So what we've done in Gloucestershire is we have a mouth care partnership across the system, and we're doing targeted training for mouth care champions. So it's practical training where we train staff to be able to deliver training to their areas to improve oral health and access to oral health. And we even have a dentist that tells you how to get access to oral health and good dental care outside of kind of in areas, particularly specifically in care homes. They provided them with training resources, so model mouths and really good useful resources about common complications with oral health and how to resolve them, so you can do some good troubleshooting in the care home, product guides about what products people should be using, oral health assessments. We've done 2 of those. We've got a 3rd one soon, and the aim is to hopefully improve the quality of oral health and prevention of pneumonia specifically in our care home communities. And I will probably stop there because I'm probably going to go over time, but they are, if you do get a chance to have my slides, there are a number of other fantastic programs that have looked at how we can get better healthcare records from inclusion health groups like Gypsy, Roma and Traveller communities, where this was a massive improved in oral health because they worked with partnering with a Traveller charity. So again, supporting that voluntary sector work. This was expanding hepatitis C screening initiatives and being in locations where there was high risk communities, saw massive improvements in testing, reduced deaths related to hepatitis C, and the reduction in a number of transplants. TB, I'm sure a lot of us have seen the Find and Treat TB mobile screening units. Again, having mobile X-ray units in hard to reach populations, seen a significant increase in identification of TB, particularly when they're asymptomatic, improved compliance to treatment, and reduction in loss to follow-up. And then this was a fantastic It Starts With Me campaign that looked at HIV testing and awareness around HIV testing and prevention methods, that again, using a slightly different approach, but targeted to the sort of social media campaigns that saw an improvement to access to particularly HIV testing amongst high-risk communities. So I'll be quiet from after this, but my message is clear, hopefully to us all, that we do need to think differently. We need to reduce the way we're going to have an impact on reducing the burden of infectious diseases is by tackling health inequalities, and we can all make a difference to that, even if it's in a small way. But we need to do that in a collective way with our patients and our communities and our service users, so we're informed that it's targeted to meaningfully make a difference, and it's going to be a continuous improvement. It isn't going to be a one-stop, like a one-hit wonder with this. We need to continually do this and make it as part of our business as usual. So I think that is me done. Thank you so much for listening.
Kerry, thank you so much. I'll let you take a sip of water and have a break.
Thank you. I appreciate
before
that.
we delve into the Q&A. Yeah, lots of people using the emojis to give you some praise, and a really fascinating, a fascinating and sobering insight, I think, into some of the challenges when it comes to health inequalities. I thought you shared some really good case studies as well. And I think, advocating for people to share the work that they're doing to help promote this and support wider adoption. I think I'm having some of the same challenges around sustainability in my role at the moment. How do we get wider adoption of these things? And I think that shared learning case studies are a really way to go. And I think you gave people loads of food for thought about how they can do that, and pointed them to some really helpful resources as well. We've got tons of questions, Kerry, so we're going to try and get through them as many as possible. So I'll start with this one, really. This is asking about health inequalities are often, the outcomes are often driven by deeper causes linked to deprivation. So the question is, why do you think we focus so heavily on the outcome and not on the root cause? And do you think we can shift this way of thinking?
Yeah, well, I'd like to think we could shift it. I think we definitely have to. Otherwise, I think we're going to be a bit broken, I think, as a kind of a world if we don't. I think part of it, I think from my experience, is that sometimes I think being in an acute hospital, we've been very much focused on you just look after the patient whilst they're with you, and you just sort of, they're in, they're out, and it's kind of, and unfortunately, I think the demand on NHS pressures has probably reinforced some of that. It's get your beds empty. We need to make sure timely discharges, and I don't think we often look holistically at how what is impacting our patients for the point that they got to an A&E admission in the first place. I think public health are fantastic at doing that. I think we can learn a lot from our public health colleagues to look at that more holistic approach, to say, actually, if we can look back a few steps and be a bit more thinking, what is contributing to this person to attend our A&E? Why are they having multiple GP? I think it's interesting that I think in that same slide that you've got behind you, John, I think there's some detail about there was the same proportion of I think it was like 20% of patients that consistently go to the same GP for their antimicrobials. That's where they're all coming from, the same patients, but no one's thinking, oh, why are they consistently coming to me with needing to have antibiotics? And it's just, here you go, have your antibiotic. It's the quick win, get out, get in, get out, and actually not thinking you've now attended 10 times, you've had this infection this amount of times. Why? And I think that's where we need to get better at. But it's a very much a shift in how we deliver, I think, healthcare, in looking at that. And I think we're getting better at it. But we need to ask ourselves why. And I think that's why I really like listening to Nikki. She was fantastic. She was saying about so things like self-discharge is something that the patient's gone out, we've got an empty bed, that's great, but there's a reason why that person is self-discharging, and it's because we're not engaging them in a way that is effectively helping them, and we don't always even look into that sort of effectively, and then we find that those poor patients bounce back in regularly because we haven't got to the bottom of why they self-discharged and what we're not doing well or good enough for them whilst they're in hospital to tackle their immediate needs. But yeah, that's I guess it's my sense, but we do need to think a bit more broadly about how we look after people.
Yeah, I completely agree. And good to hear that you think that we're getting better at it as well.
I think so. I think the system approach has helped, I think, because we don't look at just who comes out our front doors anymore. We have to, particularly, I think in Gloucestershire, we've challenged ourselves to look beyond that. Our patients are all our patients, not just when they're in our hospitals.
Thanks, Kerry.
Okay, yeah, thanks, Kerry. Really great overview. I learned a lot and really enjoyed it. So
Well, thanks, John.
Sarah asks in the Q&A here, really good question about something I've been thinking about, which is co-design. One of the ways that we can improve our services and the equity of them is by co-designing them with those who are at
Yeah.
risk or in health inequality, living with healthcare inequality. And the question is, how can we strengthen our skills to do this work effectively? Co-production and the cultural awareness that we need to do it properly, and also measure the impact of these approaches, and recognise that this requires some building of trust with key stakeholder and stakeholder groups.
Yeah, you're completely spot on. Without that trust, then we won't get the engagement. It was interesting. I was even just listening to somebody who did something with blood pressure checks, and they just taught the community group, the social kind of like the working men's club, just to do their own blood pressure checks themselves, and they were all doing it themselves because they didn't need a nurse or didn't anybody healthcare provider in there, because it was done by a trusted like mate that they'd seen for years and years and years. That's a really difficult question, I would say, to be honest. I'm going to think about what to say. So co-design, I think the first thing we need to do is we need to move how we work to those individuals that are facing some of these inequities. It's easy to say that in theory, but we do need to do that. And actually, there are fantastic, there's groups that we can go to, the voluntary charities. Most of us who work in a hospital will have a patient experience lead. They'll have, there are people that actually desperately want to make a difference in because they've experienced healthcare in your environments. And I think we need to first of all reach out to those individuals. If you've got a good communication lead, they will have so many contacts with different groups. I'm still learning, even to this day, the sheer amount of people that are desperately wanting to make a difference, and particularly in the voluntary sector. So we do have to know who those are. I definitely say reach out to your comms person first, because they'll tell you who those groups are. And then we need to listen. Properly listen, actively listen, and actually understand with empathy what those challenges are, so that we're not thinking, oh, must be this is the problem. That is, and I reference it in my talk, we do make a lot of assumptions. We think this will be the thing that's the golden ticket that will make the difference, and actually we're probably completely off piece, and we need to ask those people that are facing it. So that would be my first thing, is we need to go and listen and understand, and go to those community groups. Be proactive. Don't expect that they're going to come to you. You need to go out to them and go out to those environments. And a lot of those skills will come through that experience. If I've heard, for anybody who's demonstrated to me some of the health inequalities work they've done, often they learn on the job. There's so many things like the language and things that people use, just the slangs and the kind of commonalities of things that people do, because that's their lived experience. You'll pick up through having those engagements, having that conversation. So you will become hopefully more culturally aware as a result of that. How you measure that, I think that's where you've got some of those metrics, I think hopefully will help. It's difficult because often with clinical coding, anyone who's done try and find coding to try and help. But the starting place, I think, is we collect a lot of data, infection prevention and control already. So look at that ethnicity data. You'll have it. I've no doubt you have it already. Looking at geographical regions, we're doing that. We've been doing that with our C. diff work. We've been looking at, is there any particular regions within Gloucestershire that are more impacted by some of the infections. So yeah, you can look at your prevalence data, but make sure you're adding things like region, ethnicity, gender, age. We do collect an awful lot of demographic data that I'm sure that'll be there. We just need to be a bit smarter. Use your business intelligence colleagues to try and help you look at some of that data. But a lot of this is in my own experience. I'm sure there'll be somebody who's got lots of other ideas about it. And that's where our public health colleagues come in really well, because they do this, as I say, they do it day in, day out. They know how to do this. And that's where things like the vaccination programs are really helpful, things like that they have been, particularly through COVID, where we've looked at sort of improving inequitable access to vaccinations, and how that's made a huge difference. We need to learn some of the lessons from COVID from that point of view. So hopefully some of those models can be translated into some of our other infectious diseases.
So just really quickly, Kerry, as a follow-up, you touched on the idea of kind of building cultural awareness through experience, which is great, but how would you address the concern that you may cause unwitting offence, particularly with certain inclusion groups that may use certain terminology? You mentioned it can be really charged, and using the wrong terminology can actually inadvertently cause offence through even though there's no intention to do so. How would you, what advice would you give to somebody who is feeling a little underconfident because of that?
Yeah. And actually, I think you just have to, there's a level of being open and transparent to say, look, I may make mistakes with what I'm going to say. I'm learning here, and that's okay. I think as long as you're upfront and honest. I mean, this is just in my experience, and I'm sure people probably have much more better approaches. But my understanding is just be upfront and candid to say, look, I may make mistakes. I'm learning here. You tell me how to say things better or have things that are more appropriate, because you will, like with anything, I mean, any patient interaction you can have, you can say something that, is probably aligned with how you would speak. And, we use jargon and so many, oh gosh, our infection prevention sometimes is Greek and Latin quite literally, isn't it? So, it would be good to mindful of how we speak to our patients anyway, and our service users more broadly. But yeah, I think just be open and candid that you can make mistakes, but teach me. That's what I'm here for. We're as much as a learner as we are teachers of others.
Thanks, Kerry. A question from Helen. Do you think that national data collected in PPS and mandatory data can support the importance of health inequalities and the importance of addressing this in IPC?
Yeah, I think we could do a lot better, because we are quite we're very focused on the sort of the infectious disease aspect, but not the why. We really need to be a little bit more. I mean, this is what I love about our jobs. I always feel like a bit Miss Marple or investigators. We delve, don't we? That's the joy of our work. We look and find the whys, but we don't always collect data in the same way. It's often because it's very time consuming, and hands off, I'm not going to say, look, this is, it's not going to be a quick win, but could we do something that was going to be, when we get a PPS at the end of it, that's going to be really meaningful to understand out of that group, of those groups, when we're looking at, I don't know, pneumonia, for example, which ones of those groups have the highest burden, which ones are going to be the most vulnerable. And often we look at things like devices and things like that, but we don't look at the kind of the core nature of the kind of the individuals that we're looking at. So definitely think it's a real opportunity. I don't know how you do that. I'd need someone much smarter than me, but it would, what an opportunity to get such insights of to actually demonstrate, to do something more tangibly with, because I think we are a bit too surface level otherwise. I don't think we're quite making the impact that we can do.
Yeah, I agree. I mean, there's so much data there, isn't there? And sometimes you think you just want to delve into it a little bit deeper. I think everybody on the call is probably thinking it's time. Ultimately, working in a busy service. Maybe there's a role for AI in the future to help pick out some trends.
So. Yeah, that would be fabulous if it could.
Okay, we're not going down an AI rabbit hole. That's going to take.
No, yeah,
we're not going to go
pull us back, John.
Come back. So, interesting recommendation for the blobs and the squares as a YouTube video related to co-design from Sarah. I've not seen it. I don't know if it's any good, but there we go. Worth a look. So the next question from Graham. It's quite hard hitting, so prepare yourself. Okay, you ready? Given we've done this since the 1980s, we've been trying to address healthcare inequalities, but things have got worse. Do you see any cause for hope?
Gosh, I'd hope. I'm always a hopeful. I'm a glass half full kind of girl. I definitely think, I would say, when I'm looking back to those 1980s, it's interesting when you look at those reports, is that there's definitely, it always makes me think about Martin Keenan when he says, oh, we always have a fantastic point prevalence survey and we have all these recommendations, but do we actually do anything with it? And that, unfortunately, is what happened with the majority of these reports. I mean, the one from the Black report in 1980 had some fantastic recommendations, and then there was a change of government. It went from Labour to Conservative, and it was deemed too expensive to put any of those interventions in place, and they sort of died to death a little bit. I suspect, unfortunately, a lot of this will be quite politically driven, and it depends on who's on, who's in power at the time for a lot of things to come to fruition. So I think there is definitely hope, because I think if practitioners on the ground, the frontline staff, see that our kind of inequality aware to sort of say, actually, let's look at this through this different lens. We can make the tangible difference, even if it's small and it might be local to your area, and we share that information with others. I think you can make a difference. I just don't think we've ever properly, if I'm honest, and I know even as a healthcare worker that's probably been, around for sort of 15 years, it feels still new. I don't know about anybody else, and I don't know if anyone else has felt like this is something they've had through their whole career. I don't remember having this as an undergrad. I don't remember having this embedded in any of the trainings that I've ever had. It's been probably the last 3 or 4 years that this has become something that's prevalent to me. So if I'm honest, I don't think we've given it the try that it deserves or needs. I think the only way you get things changing is through the healthcare professionals and the practitioners that are on the ground, that are delivering the care day in, day out, and then and rallying and challenging our colleagues that are the decision makers, that have the influence in those leadership positions, to see this is the importance we have. But it's nice to now see that it's translating in our world, so it feels a bit more tangible, a bit more real. I think health inequality is this massive issue in health, can feel a bit, I don't even know where to start with that, whereas I know how to influence infection prevention, hopefully, in my job, and hopefully I can make a difference because this is affecting my world and the patients that I see. So that may be the change, hopefully.
Yeah, no, I think that's a really good insight, and I definitely agree with you on the political angle and how much of a difference that makes. I think this next question from Val kind of tags on really nicely to your analysis there. So how do we bring prevention strategies to the fore in healthcare instead of just kind of focusing on, treating people with symptoms or treating people at the front door in the acute setting? How do you think we do that?
I'm trying to think I guess part of it is passion. If you love doing what you're doing and with a prevention job, you'll do more of it. I can't say I get frustrated by doing the outbreak stuff, and the controlling bits. That's the bit that, I don't get the passion and the joy from. So it does take, hopefully, passionate people with the view that our jobs hopefully do a better impact when you do the prevention. I see constantly we're talking about sustainability. We talk about the antimicrobial. That's the greenest is the one that's prevented. That talks about sustainability, prevention, and antimicrobial resistance all in one little piece, and that can tackle it. So definitely, I think we need to, I've kind of alluded to already, we need to break down the barriers that the mouthcare partnership that we've done is something that I support and deliver in a completely different organisation than I work in, but it has an impact on my organisation, and that's why I get the support of it. So I use, I'll take a day out to go and do training around mouthcare. It doesn't necessarily impact the staff that are working in my departments and the patients, at that moment in time, but I know it will have an impact on the patients that will subsequently, hopefully admission avoided, that they don't need to come in. So it's worth that investment. So I think it's a change in kind of thought about how we need to invest in prevention outside of the areas that we work, and also it's probably having a little bit more insights and training around behavioral science and behavioral insights and how we tackle that. I think we need to I think we're getting better in our infection prevention and looking at behavioral science and using that to support quality improvement, but I don't think we quite do it tangibly, and I think so we need to upskill ourselves, I think, a little bit more to be better preventionists. So I think I've, in a tangible roundabout way, sort of hopefully
you've got it,
said that that we need to do what we need to do.
I think we got one more question from John, Kerry, and then we'll close.
No worries.
Okay, so this is from Kerry, another Kerry, sharing some experience they've had of trying to make a start with this by going into the community, into homeless hostels and other community settings where there is a higher concentration than average of inclusion groups and others who meet criteria as from healthy economic backgrounds that are deprived. And that seems to be helping them by developing some IPC audits and action plans linked to those settings. Would you see that as a good way to make a start?
Oh, absolutely. I think anything that gets you in an environment where those more, vulnerable groups are is going to get your visibility out there. Hopefully some credibility amongst those people. You develop those trusting relationships. I think it's looking at it. With any of these types of things I've said before, don't make any assumptions. So have a look at how your time and energy and effort, because it's not it's not limitless, how that could be the best, how to have the most impact. But having any kind of foot in the door, I think, is amazing, and the fact that you're going into those types of environments is amazing. So well done. I think should be really kind of congratulated, because it is easy to be in the safety of your own environment. So going out there and doing things differently is definitely to be applauded. So well done for doing that.
Kerry, thank you so much. We're just going to close with a couple of slides around some bits to advertise. But yeah, thank you so much, Kerry. A really interesting insight.
Thanks for having me.
And we'll make the recording available online as well, so for people to catch up as well. Okay, so just to close really quickly and extend a big thank you to Kerry once again. Our next Insight webinar is with Graham, who's on the call, and Graham is a big sustainability champion, as you all know, and Graham will be talking about sustainability and IPC. That QR code will take you directly to the registration link if you'd like to register. You can see all of our schedule, which is constantly updated via that QR code or on our website. We're running a journal club and a webinar alternately every 2 weeks, always at the same time on a Wednesday at 3 o'clock. And we've got a really amazing schedule actually for the rest of the year. And we're already starting the plan for 2027. Thank you to people like Kerry for making this happen. And as I just said, you can see the recordings of all these webinars as well. So if you've listened today and it's something that you think that a colleague would like to listen, then please just check out the YouTube channel. Completely free of charge. You don't have to pay anything to watch them or view them. You can share them with your organisation as well. So please have a look at our recordings on the YouTube channel. Just a quick note from our partners, the IPS and HIS. There is lots going on within both societies. You can use this QR code to look about what's going on in the IPS in terms of events, conferences, educations, webinars, etc. HIS have got fairly a good couple of things to organise, and there's HISCon running in June this year. I'll be attending. I attended last year. It's a fantastic 2-day conference with lots of speakers, so you can register using that QR code or check out the HIS website. We've also just promoting some of the HIS official journals as well. For those of you who are thinking about publishing some of your amazing research, then check out the HIS journals. There's 2. There's JHI, the Journal of Hospital Infection, and also Infection Prevention and Practice. So you can have a look at the more information. And if you don't think about publishing, then you should go and read some of the articles, because there's some great IPC research within them. You can also become a member of HIS as well, and same with IPS, and unlock some of the benefits of becoming a member by paying a small annual fee. So that's it from us today. Thanks again to Kerry, and we hope to see you again on the next webinar. Cheers, Kerry. Thank you, everybody.